I want to welcome everyone to Medical Grand Rounds, kicking off the new season, new academic year. You can look online for our full schedule of Grand Rounds for the 2022-2023 academic year. And as the people in the room know, this is a hybrid Grand Rounds all year long. We're going to try to stay in person as long as possible. And while I know that we've all gotten used to using Zoom links, I would really appreciate it and hope that more people start coming back in person for all the good reasons that it is nice as educators and as doctors to be in the same room as one another here in RC2 in the Krugman Conference Room. We have a very exciting lineup of speakers this year. I want to share that next week is Dr. Sanjay Saint from the University of Michigan. And the following week is a local expert, Dr. Swati Patel, who's one of our GI faculty, who will be speaking about the rising tide of early onset colon cancer. I want to remind everyone that once again this year we are offering CME and MOC credit for all Medical Grand Rounds. You can use the link that was sent to you in email as an announcement for this talk, as well as the link that Kelly will put in the Zoom chat if you're watching remotely. And also as another reminder for questions this year, we're going to continue to use the Q&A feature on Zoom. We'll take questions both online and from our in-person audience who are here today. And before I introduce our speaker, I actually want to introduce our sponsor for the talk today is the Excel Group. And I'm going to let Dr. Jeff Wallace introduce that endeavor.
And very briefly, there is a community of providers that have been quote unquote elected, selected, and nominated to be the expert council for clinical expertise and leadership here on campus. Actually, Dr. Anderson, Mel Anderson, and others helped bring this to fruition about 5 years ago. And that is a group that we hope will be out and be promoting clinical excellence in our community. And one of the things we've been granted the opportunity to do is bring in at least one Grand Round speaker a year. And we're so honored and pleased that Dr. Mangione agreed to come and speak in many different facets of medicine outside of just, the latest algorithm to manage whatever critical problem is on the wards. So I'm not going to say anything further other than we're honored to be part of our visiting professorship.
Thank you. Thank you so much.
Thanks, Jeff. I really do appreciate that. And now it is my pleasure to introduce and to thank Dr. Salvatore Mangione for coming and kicking off Grand Rounds here at the University of Colorado. Dr. Mangione is an associate professor of medicine at the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia, where he also directs the humanities and history of medicine courses. He did his college and medical school training in Italy, where he graduated summa cum laude from the Catholic University of the Sacred Heart. Shortly thereafter, he came to the United States, and he was an intern at Einstein in Philadelphia, and then a resident at the Medical College of Philadelphia, now known most recently as Drexel University School of Medicine, where he also completed his training in pulmonary and critical care medicine. He is a true master clinician and a master educator. He's world-renowned for his work on physical diagnosis, the intersection of medicine and the arts, and is truly impressive in his efforts to remember the Holocaust and help explain why doctors did what they did under that regime. He has been recognized with numerous awards for his service, most recently the Gold Medal from the Italian Society of Internal Medicine in 2021. And in 2022, he was named the Davies Memorial Scholar Award from the American College of Physicians for scholarly activities in the humanities and history of medicine. There are also over 100 other awards that I just do not have time to name. Dr. Mangione is a clinician educator with a long interest in physical diagnosis, medical history, community service, and the role of the humanities in medicine. In addition to his technical publications, which number many and are doubled or tripled by his speaking engagements, he's also been featured, and you may know his work from the New York Times, the Los Angeles Times, the Wall Street Journal, BBC, CNN, and NPR. He's been an invited speaker at over 100 national and international conferences, speaking often about the value of arts in medicine and how to teach bedside physical diagnosis. He's the author of a book that probably many of you have read and have on your shelves, which is Secrets in Physical Diagnosis. It truly is my honor to welcome Dr. Mangione to Grand Rounds.
Thank you so much. Thank you. Thank you so much for that wonderful introduction, for having me. It's a real pleasure. And yes, we'll be talking a little bit about observation, which is something we care a lot about, but paradoxically, we don't teach. Now, I would like to dedicate this talk to Faith Fitzgerald, who was the epitome of that Sherlockian physician I'll try to describe today. Faith unfortunately passed away last year. And 3 years ago, I was in her office just the day before she retired, mostly asking her, how do you observe? And I have to say, she couldn't tell me. She said, I don't know, I just see. And that seems to be consistent. When you ask good observers how they do it, they can't tell you. But there is a process. All right, so this idea that medicine is an art that uses science, remember William Osler's definition, it's actually not something completely far-fetched because our patron saint is St. Luke. And St. Luke is also the patron saint of artists. Remember, Luke, the evangelist, was a Greek physician, hence a good physician. But he was also a painter, and he's credited with doing the first portrait of the Madonna. So this idea that we are artists, or we ought to be, is important. And yet, as Bernie Laum put it, today's physicians are more preoccupied with laying tools rather than hands. So this artistic aspect is not cultivated. So what are we talking about? We're talking about bedside diagnosis, which for eons has been astute observation. There wasn't really much else. It was only in the last 250 years that eclectic physicians added percussion and auscultation. And these guys were artists. Percussion was added by an Austrian physician named Leopold Eulenbrugger, who, as a kid, used to go down to the family tavern and watch his father percuss barrels of wine to see if they were full or empty. That's how he got the idea. The man wrote librettos for operas, so he was artistically oriented. Now, auscultation came out of a bizarre Breton physician who wrote poetry, made musical instruments like flutes, and that's why he shaped his stethoscope like a cylinder, and also, of course, danced. So he was an eclectic guy. All of this to tell you that eclecticism seems to be uniquely intertwined with our bedside skills. Now, but in the end was always observation. All of medicine, said Osler, is observation. But he warned us, there is no more difficult art to acquire than the art of observation. So this talk is going to show you that, unfortunately, he was absolutely right. Now, how many of us at first sight will notice that Audrey Hepburn on the left has a tiara that she doesn't have on the right? That's what we mean by eye blink diagnosis, what the Germans call Augenblick diagnosis. And there is a process. Now you're going to say, who cares about Audrey Hepburn's tiara? But let me give you a practical medical example. So I'm a pulmonologist, and a few years ago, one of our fellows called me up and says, Dr. Mangione, we got a consult. I didn't see the patient, I saw the CAT scan. And the CAT scan has a chest mass, but there is also a cervical mass. And maybe we can needle that and avoid a bronchoscopy. So I said, great. Did you ask the intern if there is anything visible at the bedside? Yeah, I did. The intern said that there is nothing he could see. So we went to the bedside and bingo, the intern had missed the tennis ball. How could that be? Now, Leonardo da Vinci was a Tuscan, had a dry wit, and took no prisoners. And he said, mankind comes in three flavors. There are people who see only when shown, and people that just can't see. I always tell our students that Leonardo was incorrect. Human beings come in two flavors. There are those that have been taught how to do it, and those that haven't. And Leonardo had a good luck of having a mentor like him, whose name was Verrocchio, which is actually a nickname for Italian vero occhio, a fine eye. Now, unfortunately, there are not too many Verrocchios in medicine nowadays. And moreover, to make it even worse, we tell med students and interns and ourselves to spend 40% of our time looking at computer screens so we can bill more effectively, and only 10% looking at people. And this is the McDonaldization of medicine that has to end, because either this ends or we end. All right, so there is a wired-in problem that leads us to miss a lot. Let me give you an example. This is a study where they were training people how to take off on a flight simulator, and they told the students, make sure you keep your eye on the cockpit and you look at all the instruments. By doing that, they distracted them. So the kids did not see that there was another plane on the tarmac, and they rushed into it. They wrote it up, and you're going to say, well, tonight when I take my red eye to Philadelphia, this is not going to happen. Actually, it did happen, because what they did, they recreated the worst disaster in aviation history, where two pilots of two jumbo jets did not realize that they were both on the tarmac. How could that be? Well, the reason for that is attentional capture and inattentional blindness. What does that mean? It means that you get distracted. All right. So I want you to count the number of passes made by the guys in black. Only the guys in black.
10. 20. 30. 40. 50.
All right, so there were 20 passes, but did you realize that there was a woman with an umbrella strolling through the gym? And the
40.
funny thing is that only a fifth of those who took this test saw her because they were being distracted. Now, they repeated the experiment with a guy dressed up in a gorilla suit, which you would have imagined should have caught your attention, but more than half missed it. So what we're talking about is the fact that when you are overloaded with stimulation and distracted, you're going to miss a lot. Like, for example, enter data on the computer so we can build more effectively. Now, the causes are indeed the overload and the distraction, and also the fact that who would expect a guy in a gorilla suit to stroll through a gym? And lastly, there is a little gap between attention and awareness. So this is a perfect storm. It conspires to make us miss stuff. The solution is force yourself to pay attention. And in fact, force yourself to pay attention to detail. So here's what happens. As soon as you're born, your brain is flooded with information. And pretty soon, the brain starts filtering things out and allows only a few things to pass up and then build through pattern recognition the entire solution to the quiz. So the brain lets only a few trees in and then builds the forest. The problem is that when you become a physician, an investigator, a detective, a poet, a serial killer, a hunter, you have to pay attention to all the trees. You have to let them all in. Otherwise, your brain will fool you, will tell you that you are in the Amazon, when in reality, you're in a Mediterranean forest. So the solution is simple. Use the method of Zadig. And that is what Osler used to teach, practice, and make sure that all his students read the novel by Voltaire. So what is Zadig? Zadig is a novelette by Voltaire where this Persian sage named Zadig goes to the wilderness and becomes enlightened. Then emissaries of the king come and they say, have you seen the king's horse? And he says, you mean the mare that just delivered a colt that has a shoe made of silver and a limp? Yeah. No, I haven't seen her. So they arrest him. They think he's lying. But he's actually absolutely correct. He hasn't seen her. He's deducting everything on astute observation of footprints. In fact, paw prints, okay? So all of this to tell you that indeed the method requires attention to detail. That Zadig novelette caught the attention of Edgar Allan Poe. So when Poe created the fictional character of Auguste Dupin, the investigator that solves the riddle of murders of the Rue Morgue, based it on Zadig. And of course, Zadig was practiced by this absent-minded, handsome, lanky Edinburgh physician named Joseph Bell. This guy doubled in forensic medicine. He was an astute observer that could look at you and without asking you a question, tell you what was wrong with you, which part of town you were on, what was your job. And he did even double in forensic medicine. He's actually rumored to have solved the riddle of Jack the Ripper. But more importantly, he's the guy who trained Arthur Conan Doyle, who as a med student was so enthused by the powers of observation and deductive reasoning of Professor Bell that when he created this fictional character named Sherlock Holmes, based it on Bell, and asked Bell to write the introduction to the first volume in the series, A Room in Scarlet. And I'm going to read you a passage from that because it's a beautiful description of the method of Zadig, okay? So here's the story. Holmes is in his flat and he's doing a chemical experiment. So theoretically, he's distracted. Walks in Watson, they never met. Watson is a military surgeon that just came back from Afghanistan where he was wounded. Holmes looks at him and without asking a question says, you're a military surgeon. You just got back from Afghanistan where you were wounded. And Watson is flabbergasted. How do you know? So Watson gets told the method of Zadig. Holmes says, I knew you came from Afghanistan. From long habit, the train of thought ran so swiftly through my mind that I got to the conclusion without being conscious of the intermediate steps. But they were there. The train of reasoning ran as such. Part one, attention to detail. Here's a gentleman of a medical type, but with the air of a military man, so has to be an army doctor. And he's got back from the tropics because his face is dark, but that is not the natural tint of his skin because the wrists are fair. And he has undergone hardship and sickness, as his face states very clearly. And his left arm has been injured because he holds it in a stiff and unnatural manner. Once you have caught all the detail, only after you've caught all the detail, you can use deductive reasoning, which is actually not really deductive. It's a combination of inductive and deductive. But here it is. Where in the tropics could an English army doctor have seen much hardship and got his arm wounded? Clearly in Afghanistan, because the Brits were stuck in Afghanistan in those years. The whole train of thought did not occupy a second. I then remarked you came from Afghanistan and you were astonished. That's it. So that's what we do, even though we can't even think of how we do it. Now, Fitzgerald wrote this beautiful paper on the Sherlockian physician. And this actually applies to the emergency room when they dump in your emergency room a comatose patient and you have no idea what the story is. But the patient, with the way it's dressed and what's going on there, can tell you a lot. So there is a pleasure in being Sherlockian. It's also a lot of fun. Now, which basically means, number one, know the normal, which means when you look at the face, you look at the body habitus, the ears, the eyes, the skin, the extremities, the thorax, and the abdomen, you need to know what is normal. So you pick up the outliers. And we don't teach normal. We teach normal if you take a drawing class, because of course they want you to create a normal looking figure. But we don't teach med students where is the center of the body, how is the face divided, upper third, mid third, lower third, where are the ears based? We don't. You need to know it. For example, if you're a lay person, you look at this one and say, God, this person looks weird. But as a physician, you say, no, it's acromegalic. He has prominent bursae, he has big zygomatic arches, bulbous nose, a big chin, and he has splayed teeth because these people get megaloglossia. And in fact, Primo Carnera was a heavyweight boxing champion from the 1930s who ultimately succumbed to liver failure and diabetes from acromegaly. So let's play this game. Take Mary, Queen of Scots, who was famous for being 5'9" at the beginning of her reign and only 4'4" at the end of it since her cousin Elizabeth I decapitated her. She also had long and slender fingers, pretty much like conservative columnist Ann Coulter. And here I used to say, who hasn't been decapitated yet, but we hope soon. And then I got 2 med students report me to the dean, and the dean told me, don't say that anymore, so I'm not gonna say. Then we have violin virtuoso Niccolò Paganini, who had fingers so slender that he could play chords nobody else could. Tall and lanky was Charles de Gaulle. And finally, Vincent Schiavelli, an Italian-American character actor. You might remember him as the angry ghost in the homonymous movie Ghost, even had to get open heart surgery and ultimately was named honorary chair of a society dedicated to this condition, which apparently afflicted Osama bin Laden. So what did they have? Well, they all had what the very first patient I ever saw as a freshly minted intern in the Italian Dolomites had. It was January 1st, 1981. I had just arrived, Department of Cardiology. They said, do an HMP, everything else has already been done. She was admitted last night. She has postpartum cardiomyopathy and she has mitral regurgitation. So I went to see her and she was tall and lanky, like these folks. But also she had something unusual. She had long fingers that were longer than the palm. That is not normal. If you know the normal, they are the same length. Look at your hand. But in her case, this was arachnodactyly. And when you see that, you have to ask them to juxtapose the thumb. And if the entire phalanx protrudes, that's a Steinberg stump sign. Then I listened to her heart, and I got that wrong. It was not mitral regurgitation, it was aortic regurgitation. And then I did something that our residents nowadays, unfortunately, won't be able to do because they don't carry ophthalmoscopes anymore. But I had one, and I saw a subluxated lens. So I got out of the room and I went directly to the chief. And I said, I don't think she's got postpartum cardiomyopathy and mitral regurg. I think she's got Marfan. She's dissecting painlessly. They got very serious. They did an echo, which was the only thing they had available. They saw the double chamber room in the aorta, and then they put her on an helicopter, sent her to the University of Verona, and she was saved, and I got offered a job. So what was unique? What was unique is that tall and lanky are a dozen a dime, but not disproportionately tall and lanky. So what she was all legs. The center had been shifted upwards. 1 out of 10,000 of us have been roaming the planet looking like that, but it took 1896 years after Jesus Christ for Dr. Marfan to say Marfan syndrome. Now, who was this Marfan? He was an eclectic physician who loved the arts, particularly loved the city of Venice. And it's in Venice at the Galleria dell'Accademia that you see the original Vitruvian Man, which, by the way, is a self-portrait of Leonardo da Vinci at the age of 39. The man was handsome. And indeed, if you read on Wikipedia what Leonardo is writing in mirror image there, you realize that it's a blueprint of human proportions. And Leonardo says very clearly that the center of the body is the symphysis. Now, this is not an unimportant issue because there are lots of diseases out there waiting for our name. We just need to see them. Unfortunately, the guys that took care of him in Manhattan did not realize that he was disproportionate. This is Jonathan Larson, the guy who wrote Rent. The night before the opening, he went 3 times to emergency rooms complaining of chest pain. They thought he was a freak and he was anxious, and they sent him home on tranquilizers, and he dissected on the kitchen floor and he was dead. They didn't realize that his torso had shrunk. He was all legs. They didn't check his pulses. So the problem with you, Watson, is that you see, but you don't observe. And of course, you can observe a lot by watching. So how do we do it? This man, Tom McCrae, was the brother of Jack McCrae, who wrote In Flanders Fields, that made the poppy the iconic image of World War I. He was also the first chief of medicine at my institution, and he was a protege of Osler. And he wrote a paper where he said, more is missed from not looking than from not knowing. That's not the way we train our residents. In that paper, he writes, how careful a description can you give of the personal appearance, clothing of the last patients you saw? If you've been a thief who walked off with something from your office, could you give the police an accurate description? The people we meet on the street, those in the streetcars, all with whom we come in contact, may serve as subjects. Nothing that trains the power of observation can be unimportant. In fact, it's fun. Hence, strive to be one of those upon whom nothing is lost. My advice, and we were talking about this the past hour, is relearn how to draw. Because we all drew as kids. Then they convinced us that we can't draw. And if you say, I have to relearn to draw, I can't draw, I never drawn, call it sketching. Because we are the worst critics, of course, we're physicians. So, but a sketch, it doesn't imply to be complete and finite. So it has to be a sketch. Why is that important? Because forces you to observe the object. What you should never do is this. This gives you the illusion that you own the image, when in reality, you have no idea what's on it. And I give you an example. John Ruskin, an art critic and a watercolor painter, loved images, and he loved the city of Venice. In fact, the city of Venice recently honored him with an exhibit of his watercolors. But as soon as he got a camera, which he bought very early, he started taking pictures of Venice. And then he realized that that camera was killing his powers of observation. Threw it away and went back to do watercolors. What came out of that was the famous stones of Venice. He became such a zealot about drawing that he created a course and a book on drawing and taught anyone how to draw, plumbers. And his friends were saying, are you crazy? You want to turn plumbers into Rembrandts? No, I want to make them better plumbers. And that's the way you should see it. The reason why you should sketch or draw is to become better physicians. He drew all his life. This is, of course, the man who single-handedly invented neurosurgery. He did illustrations of his own book. This is a Cushing's illustration, and this is the area where you have to drill to get the epidural out. He was convinced and made him a better observer. Clearly, the best draftsman ever produced by our species was Leonardo da Vinci. So if you go to Florence, make sure you don't miss the Bargello Museum. And in fact, nearby is probably the best trattoria they have in Florence, Le Mossacce. Takes no reservation, but it's fantastic. But I want you to remember that when Leonardo was an apprentice in Florence, apprentice of Verrocchio, the Bargello was the prison And Leonardo will spend several months there, jailed under anonymous accusations of sodomy to the point that they were going to execute him in his 20s. And then, of course, a few good kids from good families were caught in the dragnet and they let everybody out. So that's how Leonardo ultimately leaves Florence and goes to Milan. But I want you to enter the courtyard with Leonardo on December 17, 1479. He's a free man and he's going in to see a man executed by the Republic. And he draws him. More importantly, he writes the way the man was dressed. A tan-color skull cap, a doublet of black serge, a lined black jerkin, and a blue coat lined with fur of fox breasts. The jacket's collar covered with a black and red stippled velvet, black socks, and then the name of the poor unfortunate soul. Why was he writing down that? He was writing down that because when you pay attention to detail, the big picture will take care of itself. So let me give you an example of how Leonardo saw. As soon as he gets to Milan, he paints this one, the Virgin of the Rocks. This is the version at the Louvre. Leonardo is 31. And this is typical pyramidal organization of a Renaissance masterpiece with the Madonna being the pinnacle. But I want you to pay attention to the angel, whose face, according to Kenneth Clark, is the most beautiful ever made in Western art. And I want you to notice that the angel is dressed in red, white, and green. And you're going to say, oh, that's very patriotic of Leonardo. That's the color of the Italian flag. No, there was no Italy. There was no Italian flag. Leonardo was a Tuscan. But Leonardo had painted the Annunciation angel years before in red, white, and green. And when you go to Florence, the marbles of the cathedral are, guess what? Red, white, and green. Why? Because even though they were illiterate, and not that many, there were a lot of literate people in the Italy of those years. It was only later, after the Counter-Reformation, when the church got scared of public education, that Italy became the most illiterate country. But that's another story. The point, again, is that everybody knew how to read signs, semiotics. And they knew the red is the color of love, white is the color of faith, and green is the color of hope. And those are the three theological virtues of Christianity. So nothing new. Leonardo was doing something common. We lost it, but they could recognize it. But the reason why I'm bringing this up is because I want you to look at the funny gesture the angel is making. And the Madonna is making a funny gesture. And baby Jesus looks like Churchill. So what is that? And here's where it gets tricky. To know what he's doing, you need to know sign language. And you're going to say, really? Yeah, because if you knew sign language, you realize that the Madonna is making an L, the angel is making a D, and baby Jesus is making a V. And LDV are the initials of Leonardo da Vinci. That's his signature. And you're going to say the most important word in medicine, which is bullshit. How do you know? Leonardo really knew how to read sign language? Yes, Leonardo knew that and much more. Because in those years, he was rooming with a family of painters. And the oldest brother, Cristoforo de Predis, was deaf and mute. And so Cristoforo de Predis was an illuminator of manuscripts. You see one by him there. So Leonardo actually has been credited with theoretically expanding sign language. So yes, so this is an important concept because in addition to pay attention to detail, the eye won't see what the mind doesn't know. I repeat it, the eye will not see what the mind doesn't know. So if you are not as eclectic and kaleidoscopic in your education as you need to be, you won't see it. That's why Leonardo boasted that yes, you can observe a lot by watching, but you need to have lots of knowledge. The acquisition of any knowledge, he wrote, is always useful to the intellect. So pay attention to detail, but make sure that you know a lot. The more you know, the more you'll see. Now, back to your art observation. I don't know if you do it here, but at Jefferson, we send our students to our museum to work with art instructors, which sends the subliminal message, that's not what doctors do. And the students get it very quickly. But can art observation help? And the answer is absolutely, if you do it as VTS, visual thinking strategy, which means you put the students in front of this National Gallery, and you say, what's going on? And the more they say, the more you get them to go. And if they get stuck, you say, what else can you see? Now, normally we look at this and say Napoleon Bonaparte and move on. we will spend 10 seconds on it. But in reality, what David did here was propaganda. Let me tell you why. Number one, Napoleon was a little guy, but David is using a vertical perspective and a low angle to give us the sense that the man is a giant. And he's using all these vertical lines to magnify that, including the chair. And on the chair, he put bees. Why the bees? They are the symbol of the Merovingian kings, the old traditional kings of France. So what is the message? The message is this giant is continuity with our great past. So what kind of a man is he? Well, number one is disheveled. Looks like he had a rough night. Look how his stockings are ruffled up. And yes, it's 4:15 in the morning and the candle is almost out. So he has been up all night for us, for France. Doing what? Well, that is a sword and that is the map of a country. He's a man of action. Maybe he's planning to invade another country. Should we worry? No, because he's also a man of law. That's the Napoleonic code. And we are French, so he's on our side. Plus, he's a great man. That's Plutarch, the lives of the great Greeks and Romans. So sleep comfortably, nothing is going to hit us. Wrong, because this is 1812, that map is Russia, and he's planning to invade it in the winter. But this gives you an idea of how much you can observe by watching. So how much do they get better at physical diagnosis? Tons of studies. The first one came out as a letter in JAMA. And if you do this kind of exercise, you improve the detection of physical findings by 10%. Harvard, almost 40%. That tells you already the problem with this thing. It's hard to test. But it is Sherlockian and it is fun. So I'll give you an example. Philadelphia Art Museum. My wife and I go there a lot, and she is a very good observer. So one day we ended up in front of this small wooden tablet. It's an old portrait of a Venetian lady. And the only thing they tell you is portrait of a lady, Iacometto Veneziano, 1470s, Italian Renaissance, Venice. So we start looking at her. There are a few interesting features. Number one, it's a three-quarter view, which by the high Renaissance had become standard. No frontal anymore, no lateral, three-quarter, okay? So that is conventional. What is unusual is that she's dressed in lugubrious black, which for the Venetians, forget it, was gold, green, blue, red, you name it. She's lugubrious black. Moreover, she's showing décolletage. Catholic Venice décolletage, yes, she's not having the silk chemise that was de rigueur in those years to women not to show the décolletage. So that's kind of odd. And in fact, the only accoutrement she has is a yellow scarf. Now, this is where it gets interesting. Yellow was the color of shame for the Venetians, associated with the devil, the Jews, and prostitutes. Hence, she's a prostitute. She's a meretrice. She is one of the 10,000 tax-paying prostitutes, 10% of the population, that made Venice the Las Vegas over time, okay? And they were forced by a law passed in 1416 to wear black, not to wear silk, and to wear an identifying yellow scarf. And moreover, notice that she doesn't have jewelry. If you get a serious portrait, you get jewelry, but she doesn't have it because they could not wear it. So that is the first interesting tidbit. To recognize all of that, you need to know about Venice, art history, and the Renaissance. Was she really a prostitute? Well, in the back, there is the acronym, which is Latin for the she-wolf, the lupa, devoted herself to lust, license, and lewdness. So maybe she was indeed a prostitute, and maybe this is a post-mortem. That's where your physician cap comes in, because I'm sure you saw the physical findings. You probably noticed this reddish discoloration on her cheeks and bridge of the nose. What could it be? Well, simplest explanation is rouge. This is Franz Hals a few years later, portraying a Dutch prostitute in a brothel, trying to lure her drunken customer in with a little dog that says, run away, syphilis, syphilis. But what you notice is the rouge is not applied to the bridge of the nose. Our Lady has it on the bridge of the nose, so it's not rouge. How about secondary syphilis? Well, secondary syphilis makes sense. She's a prostitute, but it's usually blotchy, disseminated. Plus, it never got to Europe until Columbus brought it there. First description from Vienna, 1498, of secondary syphilis. So unlikely. How about rosacea? It's missing the texture pattern. And so the conclusion is that this is probably lupus, the butterfly rash of lupus. Isn't that funny that she was called the lupa? And that explains indeed why she's alopecic. Did you notice her hair is a mess? People with lupus lose their hair. And yes, she was a lupa. They did not know when they named her a she-wolf that that was actually very true. Now, the lupus would also explain why she has a goiter. Did you notice that she had a goiter? And 20 to 30% of patients with lupus have autoimmune hypothyroid thyroiditis. And in fact, she even has the white eyelid that is a little lower compared to the left. And she has a bit of parotid swelling that might suggest Sjogren, also very commonly associated with lupus. And last but not least, the redness of the tip of the nose and the ears may explain polychondritis, often associated with lupus, which basically means if this is indeed the first portrayal of lupus, then an artist got there first by 400 years, because the first description in 1852 is by Cazenave, and that is consistent, and you will see it in today's presentations. The artists always get there first. They don't understand it, but they always see it. So it's Sherlockian. Now, we got a paper out of this, but what is important here are two most important rules. Number one, yes, you can observe a lot by watching, but the eye won't see what the mind doesn't know. If you don't know about Venetian history, the Renaissance, and of course, what happened to these poor women forced into prostitution, you won't realize that she was a prostitute, which basically means read this book. Alexandra Horowitz is a canine psychologist from Barnes College in New York. And so, of course, she has a dog. And she was always amazed when she walked the neighborhood with the dog that the dog was paying attention to things she didn't even see. Then she got a kid, and the kid was paying attention to other things. So she got this brilliant idea of walking her neighborhood with 11 different professionals, including a physician. And each of them saw different things. So once again, the more you know, the more you will see, which is not how we train or recruit physicians. Now, second important rule, don't see what they tell you should be there. That's how eventually Vesalius debunked Galen. Because how could you question Galen? Until finally Vesalius said the most important word in medicine, bullshit, and realized that Galen had made 200 errors. So this is Netter, great observer and a surgeon, remember? So in the 70s, Sibagaygi books, I had them all when I was a medical student, he gave us this great description of a pink puffer and a blue bloater, an emphysematous and a bronchitic bronchiectasis. In the 70s, any lung disease got you clubbing, but he gave clubbing only to the bronchitic, the bronchiectatic, not to the emphysematous. That is incorrect for the 70s, but very correct in real life. Because now we know, thanks to this rational clinical exam series, that in order to get clubbing, you need to have shunts in the lungs that allow megakaryocytes that leave the bone marrow to bypass the lung filter, go to the ungual bed, wedge themselves, die, release platelet-derived growth factor, and give you loss of the lovely bone angle. Emphysematous don't have those shunts, but bronchiectatic and heavily bronchitic patients will. So a COPD with bronchiectasis, bronchitis will have it, but not an emphysematous. Beware of clubbing in an emphysematous may reflect a malignancy. So Netter was very good at that. Of course, an artist got there first. First description of clubbing, Dick Cat. Magical realist painter from the Netherlands, died just a few months after the Germans invaded this country. And he had, of course, tetralogy of Lalot, and he portrayed himself 40 times. And in each of those oil portraits, he portrayed his clubbing. You see the loss of the lovely bone angle, you see the floating ballotability of the distal phalanx, and of course, the fact that is an abnormal pharyngeal depth ratio. And he did it in all his self-portraits. So this brings us to the issue of think in pictures. How do we think? We don't even think how we think. And I've been asking a lot of people, how do you think? You think in pictures? You think in words? And they look at me like I'm from Pluto. So then they say, think in words. A man who thought in pictures was this man. He was asked by Suzuki, and he said, words or language, as written or spoken, don't play any role in my mechanism of thought. I think in pictures. And then I have to convert that into words. So why is that important? Because if you're a visual thinker, memorization, rote memorization, which is what medical school is all about, will kill it. And Einstein hated it, particularly the German variety he had to put up with. He wrote, one had to cram all this stuff into one's mind for the exam, whether one liked it or not. This coercion has such a deterring effect on me that after I passed the final test, I found the consideration of any scientific problems distasteful for an entire year. So the Germans almost managed to turn him off. Rote memorization kills visualization. And I know, because I teach physical exam, that if I ask a med student the physical findings of aortic regurgitation, and that student can visualize the leaky aorta, he will remember that, or she will remember that for the rest of his or her life. But a student that memorizes will be able to regurgitate it for the exam, and then will have this cogitative liberatory diarrhea immediately after the exam and forget it. So visual thinking takes time. Einstein used Gedanken experiment, which literally means visual experiment, to imagine himself as a light beam, and that's how he solved the riddle of relativity. Ultimately, combining imagination is more important than knowledge. So all of this to say that if you think in pictures like him, and every single brain fart that Leonardo da Vinci had was sketched, you are going to be more creative. Plenty of papers to suggest that. Kenneth Clark says, it's often said that Leonardo drew so well because he knew about things. Much more likely that he knew about things because he drew so well. Leonardo boasted about the primacy of the visual. Leonardo probably had dyslexia, by the way. He wrote in mirror image, which is very typical of dyslexic. And here you see, you got to flip it to read it. And he says, how can you describe this art in words without filling a whole book? The longer you write, the more you confuse the listener. Draw first, describe later. And here he goes for the jugulars. Writer, what kind of words will you fetch to awkwardly describe what drawing can instead beautifully represent? Don't bother with words unless you're speaking to the blind. Don't mess with things that belong to the eyes. Don't try to smuggle them as something belonging instead to the ears. You will always be overruled by the painter. I like to verb words. What? Oh yeah, I take nouns and adjectives and use them as verbs. Remember when access was a thing? Now it's something you do, it got verbed. Verbing weirds language. Maybe we can eventually make language a complete impediment to understanding. The Babel Tower. But in medicine, this is crucial, and I'll give you an example. This is a fellow physician describing in 1800 a new condition, and I want you to visualize what he's writing. First among the peculiarities is the tooth ensemble of their physiognomy. Pale, earthy complexion, thick, pitted skin, sunk, flattened nose, scars of all fissures about the angles of the mouth give the countenance so much of peculiarity that the condition may be recognized at first sight, and the opinion is usually borne out by further observing that the subject is of short stature, has a large protruding forehead, and a heavy aspect. Can you see it? I can't. But this is Hutchison describing congenital syphilis. 1858. Exactly 200 years earlier, Rembrandt had described it in a painting that is at the Met, the portrait of Gerard de Larrey's, who was a genius in the Netherlands. The man was in his 20s, but according to the Dutch, had a nauseating appearance. Let's review. He had the bust of Perrault, the short cheekbones, the subtle nose, the protruding chin, and the raggedness, and ultimately went blind from interstitial keratitis. So Rembrandt got there 200 years earlier. So once again, I would like you to think that drawing is the root of everything. Van Gogh was right, but I'm going to leave you with a bit of sculpture, okay? And we have a cardiologist here, so I'm going to talk about him, one of my favorite emperors, and in fact, a medical school dropout and a Renaissance man before the Renaissance. So this guy loved everything that came out of Greek, to the point that in Rome, they called him the Greekling, which was not a compliment. And then they giggled because he had a Spanish accent. And then he had 3 senators executed, and the giggling stopped. Because the guy was competitive, driven, impatient, irascible, but is too short of breath to argue with you. And you, as a Greek physician, notice that the belly is swollen, the legs are edematous, and the neck veins are distended. But more importantly, you start thinking about all these nosebleeds that he tells you about. And unfortunately, Scipione Rivarocci in Pavia, Italy, hasn't yet invented the blood pressure cuff. Otherwise, you would know that the emperor has hypertensive cardiomyopathy. But you're a good observer. So you see that the emperor has funny-looking ears. And every single bust of Emperor Hadrian has a Frank sign. And it took 2,000 years for Dr. Sanders T. Frank to write a letter to the New England Journal of Medicine saying, I got a bunch of patients in my clinic with this, and they all have coronary artery disease. Frank sign. But Hadrian had it, bust in Naples, bust in Madrid, bust in Athens, bust in Florence, and even the Golden Aureus has a funny looking ear. So what are we talking about? I'm not talking about the congenital one. I'm talking about the acquired one, which is an infarct of the earlobe. The earlobe has terminal circulation. And if you infarct it, you're going to get that crease. And I tell the med students, now that you know about it, you will see it everywhere. But until then, you hadn't even noticed it. Lots of studies. This one by Dr. Elliott, 1,000 patients. 75% of those with a crease had CAD, compared to 16% of the creaseless. There are 60 studies that confirm the finding. What happened to Hadrian? Hadrian died of heart failure. And we have it by Cassius Dio. Despite his recourse to certain charms and magics, the emperor soon filled up with water, and his breathing got shorter. He was slowly dying every day, and he was asking for poison or a sword, but nobody would euthanize him. Finally, he abandoned his careful regimen, and by indulging in unsuitable food and drinks, he met his death, cursing the doctors. So he dies, and the last thing we have of this remarkable man is a fragment of a poem. Little soul of mine, roamer and charmer, guest and companion of my body, where will you soon go? Pale, cold, naked, probably to a place where you won't be able to crack jokes anymore. Actually, the Romans put him in this beautiful mausoleum across the Tiber, which nowadays is Castle Sant'Angelo. So he had it. He had it too. I paid a lot of attention to George Bush's ears during his mandate, and he developed an earlobe crease. And here you can see it very typically. And if you magnify the presidential ear, you also notice that the guy has pre-auricular crease, which makes it more likely to be real. And he also has ugly hair sticking out of the canal, which is visually unappealing, but is also a sign of hypertestosteronemic state, which means if you have it as a relatively young guy, you probably have CAD. And last but not least, in Chinese acupuncture atlases, the earlobe is a projection for the heart. So does George have coronary artery disease? And you're going to say, bullshit. George is bagging all the time. And in fact, the White House physician said he has incredibly low risk for coronary artery disease. Be careful before you make those statements. He just got stented. So George, of course, his ear knew it all along. This is me. The year the students gave me a portrait as their best teacher, and my left ear is intact. Then she ran for office, and I got an earlobe crease. So if, like me and George, you have an earlobe crease, remember that. If on an ear there is a crease, do not assume that life will cease. If hair is knotted in the ear, do not assume that death is near. So if when walking down the street, an ear with hair and crease you meet, don't give the gent a dreadful fright. Don't hint infarction is inside. It's just a sign. But see it. All right, conclusion. Flexner gave us the sciences. I think we are long overdue for an Osler report that puts back the humanities. And in fact, I personally believe that Osler has to come before Flexner. And this is actually what Lewis Thomas wrote back in the 70s in the New England Journal of Medicine. Bring in the humanists and turn them into scientists. The other way around doesn't work. Now, Osler put it simply, humanities are the hormones. Humanities and science are twin berries on one stem. Grievous damage has been done by separating them. Lastly, why do you need to look at art? To develop empathy. Let me finish with Rembrandt. Rembrandt was a master at capturing human emotions. Just look at it, the portraits he left us. And this British art critic put it simply. After spending an hour with Rembrandt people, I noticed that my entire looking changes. I get out of the museum and I see people for the first time, not their hurrying buying, I see their personality. I find coming out into the world that it makes me more human, makes me less absorbed in a world of my own, more able to see others. It reminds me of the words of Philo, of Alexandria. Be kind, because everyone you meet is engaged in a great struggle. So I'm gonna leave you now with Rembrandt, great observer. First description of congenital syphilis. First description of breast cancer on his own mistress, Hendrik Stoffels, who died of the plague a few months later, probably with breast cancer. First description of rosacea and rhinophyma on himself, and haunting description of what depression can do to us. In the year where everything unraveled, he went bankrupt, his children died, his wife died, and those eyes are painful. I wrote a paper on it. So I'm going to leave you with 2 minutes of a morphing of the 79 self-portraits he left us. The entire human condition is in that. Thank you. Thank you so much for having me. We have a few minutes for questions, I guess. Yeah.
So I've got one from online. Thank you so much for that really incredible presentation. You talked a bit in the beginning about distraction and how it can inhibit observation. Those pressures are everywhere in the hospital, pages, machines beeping, nurses asking questions. Can you recommend any tools to create more space to observe in a busy environment?
Well, other than changing the way we do business, but I think that is a big question, which means we are in a culture that is now incentivizing some aspects of our profession that are important and turns us basically into assembly line workers. So I think the first thing is awareness, as always. So if you believe that this is an important part of what you do, then you got to really start practicing and forcing yourself. This presentation gave a few suggestions. Again, I was saying today, Benny Lorber, great artistically oriented physician, plays jazz guitar, paints, and is an amazing Sherlockian physician. He's actually featured in that book by Alexander Horowitz. He told me what he does. He takes the med students to the bedside, interviews the patient, and then says, turn around, face the wall. What's on the night table? They have no idea. And then say, Dr. Lorber, who gives a shit about the night table? And he says, well, one time I was asked by the chief resident to look at a perplexing case of pneumonia. And I got out and I said, you're pulling my leg, you know. Dr. Lorber, what? You didn't see the night table? What? Didn't you see the picture of the patient with his parrot? Don't you think he has psittacosis? So the point again is awareness. There are certain exercises, then it's practice, practice, practice. It's the 10,000 hours of Malcolm Gladwell. And yes, I wouldn't mind, and that's why I'm trying to talk to the young generation, for the young generation to rebel. Remember the last words of Bernie Lown, doctors revolt. We need that different way of doing medicine. My wife, unfortunately, has ovarian cancer. The past 2 months has not been fun, and we've saw medicine from the other side of the fence. And I think the fact that we are hurting through our burnout says that we're not happy either. So, but this is not something that we test with a single best answer, black and white multiple choice exam. So it gives you a sense of why there's more that goes into that unique cocktail that makes a good physician. So my suggestion is, if you think this is important, cultivate it.
Thank you so much.
Dr. Mangione, thank you very much for that talk. What does your curriculum look like? So when you have control of this and you can have the students, at least, if not the residents, what do they do? And maybe even what more might you want them to do if there was more time?
Well, just to give you an idea, we have some very good people in clinical skills at Jefferson. People have written books and papers. There is no physical diagnosis course anymore. We went PBL. Everything is incorporated. We used to have 16 hours. The students love it. I have people that graduated years ago that still come and say, thank you for what you gave me, as if it's gone. So what do? I run selectives. And in those kind of selectives, I'm trying to change medicine one medical student at a time. But no, the general trend, even at our institution, isn't there. So what needs to be done? I think what we outline, so for example, we were talking about creating a selective. University of Oklahoma has one on observation. So thinking a little bit out of the box. So I run selectives on that. I have one I have a medical cineforum, because you can discuss issues that are really relevant, like end of life, like eugenics through movies, and get the students to think. And then, of course, I have a history of medicine course, but I don't do exoteric. I do things that are applied to what they do now. You know, so the role of physicians in hiding diseases of leaders and changing history, the role of physicians in the Holocaust, you know, things, groupthink. So I think ultimately we need students to think. And so for us, I think that's the challenge. The system is not conducive.
Sounds like we need some monthly art outings. Dr. Connors, you in? Yeah.
Yeah, if we have a second here. So I guess I wanted to ask about, I saw you had a paper by Simons up there, and that work was inspired by Kahneman and Tversky and decisional analysis and those things. And they point out all of the flaws that exist between what we see and what we think we know and what is true. And that gets into the idea of implicit bias. You know, so you have your observer and they come to things with their biases and they see something, they make a decision on that. How do you factor that into this process? Because each one of us is going to see different things when we are looking at the same object.
Right. And that again goes into the issue of how comfortable you are with ambiguity. And clearly, when you talk about bedside diagnosis, you are awash in ambiguity. You know, the feeble sound you detect with your stethoscope, the organ that you think you can palpate, and then you throw up your arms and say, get a CAT scan, get an echo. But at the same time, if you get comfortable with ambiguity, plenty of data, you're going to become a more effective physician. So that's why, paradoxically, it's built in the difficult art of medicine, but it's actually good training. So yes, it has to be acknowledged. But I don't think it's a weakness. Paradoxically, it's almost like a strength. because it trains you for something very important. Yeah. But yes, it's rife with ambiguity.
Any other questions in the room?
Where are the residents?
They are probably in their workrooms, so that's okay.
Yeah,
Yeah.
yeah.
But thank you. And I want to thank you very
Thank
much
you
for
so
coming.
much.
Yeah,
Thank you
really
for having
appreciate it.
me. Thank you.